they open their bowel every day, single a day. Some people, they open their bowel every 2 days. So there's quite variation between person and person. And this is called bowel habit. So the bowel habit, which is the, you need to know when you're approaching a patient with diarrhea, you need to know the usual bowel habit for a patient. Then you ask him about what is the change. Either in change of form of watery diarrhea, increase in frequency, reduction in constancy, or an increase in frequency. So we mean this patient's having diarrhea. While if the patients have increased constancy and increased reduction in frequency, we call it constipation. So you need to understand the habit of the patient. Then you will ask about what is the abnormality. But there is a good term that loose or watery diarrhea, definition of the diarrhea, there is loose or watery stool, past 3 or more a day, or either increase in stool frequency and volume and diminishing stool constancy. In children, because the constancy of the stool and the frequency of the stool, it is difficult to know whether this patient have diarrhea or not, so they put a scientific term on scientific definition, which should be more than 10 ml per kg. While an adult or a person or child above 2 years, so it has to be more than the stool weight, more than 200 grams in order to say diarrhea. But as I said to you, the definition of diarrhea, you need to know the habit of the patients, and then if there's an increase in frequency or reduction in constancy at any day, you mean that the patient goes in the direction of diarrhea. This is very, very important slide. If you understand this slide, you will solve any diarrhea or approaching the patient with diarrhea in a second. But if you don't know this, what is the content of this slide, you will be taking question without knowing what is going on. So there is certain help. There is certain help for you to ask the patient certain question in order to classify this diarrhea whether in terms of chronic diarrhea, whether in terms of the inflammatory diarrhea, because there are many classifications. And one of the important classifications, I usually ask the patient, if the patients have diarrhea, the first most important question is to ask about the duration of diarrhea. Because the approach of patient with acute diarrhea is quite different from approaching a patient with a chronic diarrhea. Okay? So we classified it according to the time course into acute diarrhea or chronic diarrhea, according to the duration. We also classified the diarrhea into low volume or large volume diarrhea. And we're going to see in the next few slides what is the difference between those. Well, according to the pathophysiology, whether it is osmotic or secretory, what is the constancy of this stool? Whether it is inflammatory, steatorrhea, fatty diarrhea, or watery diarrhea. Or according to the epidemiology. And if you look at the last statement, usually we are as a physicians, usually we help ourselves with 2 or 3 approaches in order to reach the diagnosis of diarrhea. Okay? So we will start with the duration. If you approach a case coming to you, I have a diarrhea for 3 or 4 days, you will keep in mind this is most commonly an infectious diarrhea. While the diarrhea, the patient told you I have diarrhea for 1 year. So this is a chronic diarrhea. Might be malabsorption, might be pancreatic disease, might be biliary disease, might be celiac, might be inflammatory bowel disease, or might be irritable bowel syndrome. So these are important. But if the patients have a diarrhea for 1 week, you think about infection. So normal, healthy person, there is no prior history of the illness, is coming with sudden onset of diarrhea. So you think this is a patient having food poisoning. If the patient have like what is called subacute diarrhea, it is more than 7 days, you think about this is might be the protozoal infection, because the most common cause of acute diarrhea is, what is the most common cause of acute gastroenteritis? فايرال. هي حظي يعني انا شو سالته هذا حكيته بالمحاضره وجيت اكثر بالام سي كيو بالاوسكي. الكيس كانت دياريا، سالتهم هذا بيشنت عنده 3 days دياريا، جايب لهم سمبل، جبت كيس اوف دياريا، واحد قعدناه سيميوليتر قال لهم عندي 3 ايام دياريا. اقول له شنو الموست كومن كوز؟ ايكولا. شنو الموست كومن كوز؟ كلوستريديا ديفسيل. يا اخوان فايرال. هذا اللي يصيحوا له الامهات يقول له دكتوركم شتاء البارده. هي مو بارده، هي الفايرال انفكشن، روتا فايروس، خصوصا بالبدايه. روتا موست كومنلي كوز. زين؟ بس احنا ما عندنا الروتا انتيجين على مود كونفيرم دايجنوستس، وهي هسه راح تشوفون انه we don't do the more sophisticated investigation in patients with acute diarrhea. So when you encounter a patient with acute diarrhea, the most common cause is viral. Second most common cause, bacteria. If it is delayed for subacute more than 7 days, protozoal. So, and there is a few organisms that can cause the chronic, more prolonged diarrhea, especially in immune competent, like Yersinia. This is one of the causes that can cause more prolonged diarrhea, which need a sophisticated culture in order to make sure this. But chronic diarrhea is not usually caused by infectious agents. هذا عرفناه. هسه احنا اول سؤال تسأل المريض اذا عنده قال لك يابا انا عندي اسهال. The first question for the patients is that what is the duration of your complaint? What is the duration of your run? So the question, if the patient told you I have more than, so the limit, one of you will ask, what is the limit between acute? So some books say 1 month, and above we regard chronic diarrhea. 1 month and below it regarded as acute diarrhea. Some books say 2 weeks. 2 weeks, especially the new text, they regard 2 weeks. 2 weeks and above is chronic diarrhea. 2 weeks and above, chronic diarrhea. But in our practice, we see that 1 week we regard it as acute diarrhea. 1 to 1 month subacute diarrhea, more than 1 month or regard chronic diarrhea. Because the approach will be quite different, as we will see. The second most important question to the patient, what are the volume of diarrhea? Whether it is large or small volume. The large volume, it means that the patient's source of the diarrhea is usually the right colon or small bowel. While the patients have a small, frequent, painful diarrhea, is the source of the left colon. Anyone will answer? What is the difference? أكو واحد يجاوبني? Why the patients with left colitis usually they have small, frequent diarrhea? Why the patients with small diarrhea, small bowel diarrhea, will have large volume diarrhea? Yeah? So why? Why those patients with left colitis or bronchitis, they have small diarrhea, small, frequent, painful diarrhea? While patients with a small bowel diarrhea, if they decide to small bowel, usually they have large volume diarrhea. Anyone? Excellent. So, what is the function of the rectum? The rectum is the stomach of lower GI. It's the function of reservoir of stool. So, if this function, the mucosa of this become inflamed, the reservoir function will be lost. So any stool will enter to the rectum, will be passed directly. So this is causing frequent painful diarrhea in case of bronchitis. Okay? So this is the why the patient with rectum, because the reservoir functions of the rectum will be lost and then will lead to the small volume, frequent painful diarrhea. While patient on the right colon, on the small bowel, there is no reservoir. The reservoir function will be maintained. It can pass the fluid for the large accumulated in the rectum and then will be passed directly because the function of the rectum will be reserved. So that will be large volume diarrhea. Someone will ask, how can I assess the patient whether it has large volume diarrhea and from low volume diarrhea? So imagine if the patient doesn't have vomiting and he told you I have diarrhea, I go to the toilet every 1 hour, every 30 minutes, and then you assess the patient, you find a significant level of dehydration in terms of what are the features of dehydrations? جالسين هون صدقوني انا امتحنت يمكن 60 طالب يمكن 10 جاوبوني ساين اوف ديهايدريشن. اول شيء اقول له يابا باوع الفيس وين تفحص الديهايدريشن؟ زين؟ يقول لي بيل فيس. هسه ما يخالف اذا significant ديهايدريشن بسبب هاي عديتها قلت له انا درايم ينقص منبرين. يصير التب مالته مثل الخشبه. درايم ينقص منبرين. إذا طفل sunken fontanel, dry eyes, بعد skin tear lost, capillary filling يتأخر, oliguria, hypovolemia, no sweating. All these are features of hypovolemia, okay, and dehydrations. So imagine a patient especially with cholera. Why the cholera is killer? Cholera causing watery diarrhea, significant watery diarrhea. And because if you follow a patient with cholera with idiot doctors, and he doesn't know the patients have large volume diarrhea, and the patient can pass in severe dehydration and severe electrolyte disturbance and can pass away. Because of you couldn't assess fully that the patient have significant dehydrations and you do not know significant large volume diarrhea. So the same things, if the patients have, how do you assess the volume of diarrhea? If the patients have significant dehydration and there is good oral intake and there is no vomiting, it means that these patients have significant loss of water and electrolytes. Okay, so frequent small diarrhea, it means the source will be rectosigmoid, left colitis. While large volume painless diarrhea, it will mean that right side colon. Osmotic versus secretory. Osmotic, it means that there is certain osmolar foreign enter to the body. It will take the electrolyte and water and causing diarrhea. Okay? Usually is a carbohydrate malabsorption diarrhea. Chewing gum, sorbitol, sweetener, all these can cause the osmotic diarrhea. How we can, while secretory, it means that the channels that secrete electrolyte and water will be activated. It doesn't need osmolar, doesn't need phoninol. It means that there is inflammation of mucosa, and the mucosa and the channel inside the mucosa between the cells will be actively produce water because of toxin, because of the virus, because of bacteria. How we can differentiate between the osmotic and secretory diarrhea clinically? In simple question. Secretory diarrhea will not stop during fasting. While osmotic diarrhea, if you cut the source, will fade. So the patient with osmotic diarrhea, usually they told you that my diarrhea will be better when I sleep. Or the another question, if you ask him, do you awake at mid of night to go to toilet because of diarrhea? So it means nocturnal diarrhea. In patient with secretory diarrhea, they say yes. While in osmotic diarrhea, he doesn't awake because he doesn't eat. Usually patient with osmotic diarrhea become better in Ramadan month because of fasting at the day and night. While patient with secretory diarrhea will not. Another way in order to differentiate is to measuring anion gap. The anion gap will be elevated because of the presence of foreigner osmolar that can increase the gap between the normal osmolar. While in secretory diarrhea, there is no high anion gap. It's less than 50. So these are the difference. Just as the patient, whether the fasting fade the diarrhea, it means that the patients have osmotic diarrhea. Or if the fasting doesn't fade diarrhea, it means that the patient has secretory diarrhea. If you are in doubt, just send for the stool osmolarity in order to solve the patient's problem. This is a very important question for the patient in order to know the content of the stool. Because you will see in the next few slides, if the patients have a blood in stool, or milk, like مسحر الجراحة pus in stool, this is mean the patient have inflammatory diarrhea. Your approach of patients is quite different from patient having just watery diarrhea. If the patient told you I have like fatty diarrhea in form of a greasy, glistening, difficult to flush in the bowl of the toilet, it means that the patients have fatty diarrhea. Okay? Epidemiology. It's very important to know the epidemiology of the patients. Imagine if you are in a travel or going to the camping or eating in a restaurant, 3 or 4 of your colleagues having diarrhea. So this means that the patients have infectious diarrhea. I mean there is 4 microorganisms entering to the body in order to causing acute diarrhea. So if you know the situation, the epidemiology of the patient, you will solve the patient, you will reach the cause and the diagnosis in the one question. If the patient has diabetes, if the patient is diabetes, you know the diabetes can, insulin-dependent diabetes is associated with celiac disease, and so patient with diabetes, they take metformin, which is causing diarrhea and malabsorption. Patient with chronic diabetes can cause diabetic neuropathy and cause peripheral neuropathy, and the peripheral neuropathy causes autonomic neuropathy and causing rapid bowel secretions and the rapid movement of the bowel. So the patients, all these, it can happen only in one patient with diabetes. Patient with oncology causes like tumor or radiations, can have chemotherapy-induced mucositis, radiation-induced mucositis, side effect of medication, and if the patient have a neuroendocrine tumor, there is certain hormone-induced tumor. So if you know the situation of the patient epidemiology, you will know all the causes behind the diarrhea. If the patient is elderly and he's taking admitted to the hospital and taking antibiotic, this will raise the possibility of what? Clostridial diphtheria, C. diff toxin. So C. diff toxin, when the patient's having 2 of the following: elderly, taking antibiotic, and having hospitalized recently. So this is, if you know the story of the patient, the epidemiology of the patient, you can solve you reach the diagnosis without needing further investigation. So we're coming to the end of the 5 approaches of the patient. Ask about time, durations, ask about the epidemiology of the patient, ask about volume of the patient, ask about the content of the stool and whether it is secretory or pathophysiology. That's why when you come to the patient, when you will come with me in the clinic, in the gastroenterology hospital, so when you meet the patients with diarrhea, you need to ask them this question. What is the duration of the diarrhea? What is the content of the diarrhea? How frequent? What is the volume? If you have chronic disease or not? If your friends having the same condition, especially in acute diarrhea, having family history of IBD, do you take chemotherapy? So drug, social, family history, systemic review, and all these questions that you need to consider in the patient before you launch your approach and investigation. Okay. So these are one of the important questions that you need to ask further for a patient. As we say, duration, onset, pattern, epidemiology, stool appearances, fecal incontinence, weight loss, aggravating factor, alleviating factor, previous evaluation, the drug intake, factitious diarrhea, and systemic insult. So these are important because I saw many students when the patient have a diarrhea, they have all astonishing. They become silent. He doesn't know anything to ask. Please ask him about the duration. Please ask him about whether the patient have abdominal pain or not. What is the patient having large volume or small volume? If there are any feature of dehydration, if there is any systemic illness, if there is recent surgery. So blah, 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 in order to come, because the area is very important. Topic you need to cover all. So if the patient's having, I bring one of the cases, which is acute diarrhea, as I told you before. So no one, some of you or student of your colleague doesn't ask about the first important question, which is the duration of diarrhea. So diarrhea, you have diarrhea, just عندك وجع راسك شو واحد عندك ضيق بالنفس. It's not systematic history question. So you need to take what is the content of the stool, what is the duration of stool, do you have abdominal pain, is there a blood in stool, blah, 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 3 few questions, and it will be finished. Okay, so acute diarrhea. So as we said before, acute diarrhea is most likely infectious agent until proven otherwise. It's usually self-limited. Even if you don't take antibiotic, you don't take any especially if it's simple, the immunity will function to clear the viruses or the bacteria. The gastroenteritis is the misnomer for the enteritis because there is no inflammation of stomach in patient with diarrhea, acute diarrhea. What is the source? The fecal-oral transmission of microorganisms. But keep in mind, there is certain drug which is famous to cause diarrhea, like acid intake, antibiotics, cytotoxic, and PPI can cause the diarrhea. The most hazardous complication is dehydration. So when you meet a patient with acute diarrhea, your job is in two things. You have to assess the patient whether he has significant dehydration or not. So you need to assess the features of dehydration, look to the mouth, look to the eyes. If the pediatric, look to the sunken fontanelle, look to the filling, look to the blood, measure the blood pressure and pulse rate, measure the postural drop in order to look for the postural hypotension. Then assess for renal output, because patient with significant dehydration lead to the oliguria. So first job for you is to assess for dehydrations and to give a treatment to rehydrate the patients, whether in form of oral intake or IV in case of severe dehydrations or the patient cannot take oral. When the patient cannot take oral? ليش يصير عنده داعي؟ بالعكس يصير عنده constipation. شوف اجوبتكم ما شاء الله. Why So the question, when I will give IV infusions of a fluid for a patient with acute diarrhea? The first answer, when there is severe dehydration or severe hypovolemia, in order to correct the electrolyte and to correct the loss in the water. So what is the second indication to give the patients IV instead of oral rehydration solution?
Unconscious.
I know you are not so knowledgeable about the clinical examination and clinical scenario. A patient with diarrhea, we do not have a patient with unconscious. He's not a stroke patient. He's not a comatose patient. So the patient, it can have a drowsiness because of severe dehydration, but unconsciousness in case of, so hypotension doesn't cause coma. It can cause fatigue, can cause blackout, it can cause the postural dizziness, but never ever cause hypotension, coma. Okay? I said if there is significant hypovolemia in form of shock, this is the first indication. This is another signs of significant hypovolemia. والله العظيم سألت هذا السؤال بالسيشن، كانت جابوا لي طفل جاء كذا يعني، فقلت لهم ايش تبطوا مغذي لو تبطوا هذا الماي، جابوا الماي ام الطفل، قالت لهم هو ما يقدر ياكل يتقيأ، شلون تبطوا هذا يريد له مغذي دكتور؟ يعني شنو؟ يعني بيشنت with repeated vomiting يقدر ياخذ اورالي؟ لازم اعطيه اي فلويد. A patient unable to take oral intake. It's a simple answer. You need to look. The English people usually they teach us that you look to the concept, not to look for the content. These lectures and all the books and articles and research and papers, they are filled with information. If you look for all this information, you need like a plenty, or you need not your mind, you need like a computer with 1,000 giga in order to put all these informations in your mind. So if you are looking what? To the content. But you need not to look for the content if you are medical doctors. You need to look for the context. What does that mean by context? What is the difference between content and context? Who is very smart in English language? What is the difference between content and context? حد يكون عارف الانجليزي؟ يا شلون تحكون انجليزي؟
سياق المحتوى.
ها؟
سياق المحتوى. Context is سياق. Content محتوى.
The content is content. محتوى and the context مفهوم or concept. So you look for the concept, the idea. If you understand the concept, you don't care about the content of these things. If you understand the context or the concept, this is the idea. So if you listen for stories and you understand the topic, why I'm measuring the blood pressure? Why I'm the pulse rate that I told you in the case scenario is elevated? This gives me a hint. Why the patient, many patients, they consult the doctors with iron deficiency anemia. Iron deficiency anemia. What do they do for him? They give him iron pill. Is that right? Is that enough? No. Because you need to reach the cause. If you look for the iron deficiency, so many patients, even the medical graduate, they come, doctor, can you prescribe iron pill for me? Why? Because I have an iron deficiency. How much? The HP of 7. So he just needs an iron group. Have you looked for the cause? Have you find the cause? You might have celiac disease. You might have polyp, bleeding polyps, tumor, peptic ulcer, varices, gastropathy, which all these lead to the iron deficiency anemia. So when you're approaching a patient with iron deficiency anemia, if you are looking to the content, you're giving just iron pill. Anemia will give it iron. Iron deficiency will give it. But if you look to the concept and the context, you have to look for the cause. So the idea behind any symptoms, if you ask a question, you throw a question for a patient, you have to mindset, mind map, algorithm in order to what goes with and what goes against this question. I'm asking this patient question not in order to fulfill like a form, but I am asking the duration because I need to differentiate between acute and chronic diarrhea. I'm asking about the content of stool in order to look for whether this patient having inflammatory diarrhea or watery diarrhea or fatty diarrhea. I'm asking about the epidemiology in order to look whether if there is any association, whether it is diabetes or chemotherapy intake or having food poisoning for a mass people. So this is the difference if you are approaching. So again, look beyond the horizon, as the English people say. Look beyond, not like the donkey is looking just for his in front. Okay? So these are the other causes for the acute diarrhea. So look, the infectious causes on the top, but we have another cause, as we say, drug, food allergies, disorder of digestive, chemotherapy, surgical condition. You remember I told you you have two jobs in approaching a patient with acute diarrhea. The first, assessment for dehydration. The second, what is the second job for you on a patient with acute diarrhea?
Renal
And dehydration? Severity will cause. Okay. Now what? Help me. So the second job is to rule out surgical condition. Because many surgical conditions can be presented with diarrhea and abdominal pain, especially acute appendicitis. Many patients visited my clinic, they are suffering from acute diarrhea for 3 days and significant abdominal pain. Does that have gastroenteritis? Maybe have gastroenteritis, may have acute appendicitis, maybe have diverticulitis, maybe have cholecystitis. Can be presented with acute diarrhea and abdominal pain. How we can differentiate between those surgical conditions and the gastroenteritis or medical condition? Anyone?
Character and site of care. Character and site of care.
Yes. How come?
يعني مثلا بالابندسايتس غالبا ما راح يصير كوسه.
Okay.
صعوبة يعني.
Yes.
Severe pain.
So you are right. So in surgical condition, usually you have localizations. So the patient with acute appendicitis, in the history and in the examination, you find a localized pain. While in patient with gastroenteritis, the patient pain, usually in form of a cramps, generalized abdominal, not significant pain. I put that in this approach. So patient with gastroenteritis, patient usually they have abdominal cramps, colicky, mild abdominal colicky pain. And when you do examination, you will find a generalized mild tenderness. But in a patient with diverticulitis or acute appendicitis, you will find a localized pain at the certain site of patient examination. Whether in the left side diverticulitis, you will find the left side lower abdominal tenderness. While in the acute appendicitis, you will find a rebound and tenderness in the right iliac fossa. While in patient with gastroenteritis, patients usually have a mild abdominal pain, generalized, There is no localization. Okay? Is that clear? So your job in a patient with acute diarrhea, it will depend on two things. On dehydration, to assess the dehydration, as we say, blood pressure, rhino mucous membrane, sunken eyes, sunken fontanelles, oliguria, postural hypotension, increase of pulse rate, dry skin. All these are features of dehydration. If the patients have dehydration, you need to start the rehydration treatment. When? Either we start with oral dehydration, if the patients have simple dehydration, or the patient can take oral. If the patient cannot take orally or have significant dehydration, I will start with IV. And the second job is to rule out the possibility of surgical approach. Look to the history. We start with stool characteristic associated enteric symptom. There's another important thing that I need you to know. The diarrhea, vomiting, and nausea, it can happen as a primary GIT disease or can happen as a secondary to the systemic inflammation. What I mean? If the patients have, imagine, if the patient have COVID-19, some of those patients can be presented with nausea. If the patient have like systemic inflammations, they can be presented with nausea and vomiting and diarrhea. Imagine if the patient have viral hepatitis. You know the hepatitis A, B, and E can be presented with acute hepatitis. Do you know the prodrome of the viruses? How many stages we know? You know about these stages of virus? Stages of viral infection. Stages. 1, 2, 3, 4. Stage 1. شو يسمونه؟ قبلها. حضانة من صحة الطفل إذا سألنا يقول لك الحضانة اللي يجي أول شيء incubation period, which is completely asymptomatic, and only the serology will be positive. The second stage, prodromal stage. This stage have generalized systemic symptoms in form of nausea, vomiting, diarrhea, fatigue, malaise, and high-grade fever. So all these symptoms can happen in the prodromal phase. That is why patients with viral hepatitis, usually they are treated with as a gastroenteritis. Patients with COVID-19 can have this and can go for doctors and they can start it for them flagellates for diarrhea. But stage 3, it is the systemic stage. If it is COVID-19, respiratory phase, a viral stage, hepatitis, ecteric phase. Then the times to appear jaundice. And this time, the patient consults us as a hepatologist. But initially, they have 3 or 4 days with the prodromal symptoms, and if he consults the doctors, he will be treated as gastroenteritis. But that is why in the lectures I usually told my students that you have to have high index of suspicion about viral hepatitis. And any patient coming with prodromal, fever, malaise, nausea, vomiting, diarrhea, you have to think about viral hepatitis. So you have to send not only for CBC or CRP, but add liver function test with it in order to look for enzyme, whether it is elevated or not. And the last stage is the resolution stage. So disappearances and immunity will build up by viruses. This is the usual 4 phases of each virus. So what is bringing us to this stage is the vomiting and diarrhea, which can happen not due to the GIT source, not due to bowel inflammation, but due to cytokines and hormone stimulation. As autonomic stimulation, it will cause diarrhea. So diarrhea can happen as a secondary to the systemic inflammation, like the fever is happening in diarrhea. Okay, so you need to discriminate. So imagine yourself as a midnight, one of your uncles or aunties or grandpa, grandma called you, you are a junior doctor, can you help me? I have an acute run, I go to the toilet every now and then. So what do you tell them? Do you tell them go to the emergency to solve your problem? Stay at home? So you need to ask few questions in order to help your relatives with good treatment, or either you know the patient's symptoms well, ask him to go to the emergency, to take certain pill, or just to take rehydrations and wait until morning. So if you know these few approaches, you will solve this patient problem, assessment for dehydrations, whether the patient has significant abdominal pain or not, whether the patients have other symptoms, fever, systemic insult, what is the epidemiology, what is the content of stool, then you will answer the patients in the right and guide him to the right direction. Again, this is a simple table in order to differentiate between watery and, large and small bowel. We spoke about all of these points. So as you can see, small bowel, usually watery, while large bowel is bloody and mucoid. The volume, as we said, that right colon or small bowel usually large, while large bowel is small. So increase the frequency in small, highly increase in large bowel. The blood is commonly grossly in large bowel, but less in the small bowel. pH. Why the pH is reduced in small bowel and the pH is high in the large bowel? Diarrhea. Of what? Of carbohydrates. When there is malabsorption of carbohydrates, it will lead to the decrease of the bowel. And the absorption of carbohydrate happens in small bowel, not in the large bowel. Serum white BC because of signs of inflammation happening in large bowel. The viral is most common cause of small bowel bacteria, basic bacteria in large bowel. What is your workup? Usually we don't need a workup in patients with acute diarrhea. Just symptomatic treatment, oral rehydration. Just, you don't need to give a treatment. But I will show you what's happening. When do you need to treat the patient? In certain situation, when the patient is immune compromised, when the patient having volume depletion, hypovolemia, when there is severe toxicity, frequent vomiting, debilitated patients, so that this time you need to treat the patient rapidly. What is your workup? The first investigation that you need to know in order to help yourself with acute diarrhea is general stool exam. سألت من هذا غلبهم جابوا الحمد لله. كلهم جابوا قالوا شنو الأول تيست نسويه بالأكيوت دياريا؟ جنرال ستول اكزام. السؤال اللي ما جابوه ايش يحتوي الجنرال ستول؟ هذا ما حد ذكر. الجنرال ستول يساعدك تشوف الأوفا والبروفوزويد مع الباراسايت أو البكتيريا. تشوف الباسيل ليكوسايت كاونت. زين؟ تشوف البي اتش ده ولا لا مختبر زين يدزلك انا متميز وحتى نقدر نحسب الانيون ده بس احنا سمبلي الجنرال ستول نشوف عنده ساين اوف انفلاميشن عنده بروتوزوا على مود نعرف انه هذا البيشنت صدق عنده جاسترونترايتس. اذا بيشنت عنده ساين اوف توكسيميا ساين اوف كولايتس in form of bloody diarrhea او increase fecal pus cell or increase fecal carbohydrate. ذولا يعني بعدهم ما مستجابين نقدر نسوي لهم ستول كلتشر. هسه يجي واحد يقول لي دكتور انت تدز ستول كلتشر اقول لك بحياتي ما شايف. اغلبهم if you approach the patient in the right way we can solve the patient problem without need for this is sophisticated investigation. بس احنا حاطينكم اياها على مود تعرفون انه what is the next stage if the patient not responding to usual treatment. So the next stage is to do culture. When I will do the culture, when there is sign of colitis. Fecal antigen اكو recently بعد ما يحتاج general stool exam ولا the stool cultures. Usually I sense for serology, for rotavirus, for giardia. Unfortunately, we do not have. Of course, in case of severe diarrhea, you might need to do some blood investigation to look for severity. CBC, serum albumin, fecal alpha-1 antitrypsin, and sometimes in patients with severe diarrhea not responding, acute severe diarrhea we do not treat it. We do not do the workup. But sometimes we need to do even endoscopy, colonoscopy, and take biopsy in case of not responding to treatment. Abdominal X-ray in case of to look for the complications like ileus or megacolon. يعني هاي this the workup, all the workup that you need. But is it practical in our society and our situation? It's not practical. Only the general stool we do usually. But all these sophisticated investigations, usually we do not do it unless the patient not responding to the usual treatment. So, again and again, acute diarrhea is usually infectious agent, often self-limited. When do you treat it? Most patients, which is not toxic, we treat with rehydrations. So just rehydration with the fluid and chloride treatment. When do you need to treat? Again, if the patient has sign of toxemia, bloody diarrhea, high-grade fever, abdominal pain, volume depletion, older the age, hospitalized, pregnant patient, food handler, immunocompromised. All these patients that you need to do your workup and to do some treatment other than the rehydration. اكو معلومه صغيره على الاورال rehydration solution. الاورال rehydration تعرفون ايش يحتوي؟ What is the content of oral rehydration solution? Electrolyte, glucose, بعد water. يعني هو انت راح تحطه بوتر بس هو المحتوى مالته الكترولايت والجلوكوز. ليش حطوا الجلوكوز؟ هو مو صار لنا ساعه نسولف على الالكترولايت والوتر جاب الجلوكوز بالنص. يعني هذا الستايل اكو قسم من عندهم يقول لك قلت له مثلا زود الفلويد مالتك يابا سوي خذ سوائل هذا يقول لك انا اشرب هذا الجوتريت يصير هذا اللي بيه الكترولايت مشروب الطاقه او شنو زين بيه الكترولايت مينرال كافي وليش؟ هذا ما بيه جلوكوز. ليش نحتاج جلوكوز in patient with diarrhea؟ مو هذا السبب هو هذا. Why? Excellent. So the channel, usually active channel, need ATP. The channel that introduce water and sodium is active channel. It's not passive channel. So it needs ATP, energy, glucose, in order to help accelerate the entry of the electrolyte. So in any patient with dehydration, if you give him just plain water يقول لك دكتور اعطيه نقول له يابا خذ فوح تمن وهاي زين بس فوح التمن واحده ما يكفي هذول المينرال ووترز ما يكفن يكون ياخذ ويانا جلوكوز على مود شنو؟ يسرع الانتري اوف الكترولايت. اوكي؟ امبريكال تريتمنت هسه يجي هذا الحكي كانتنا هسه صار يقول واحد من عندكم يقول لك دكتور انت صار لك ساعه ولا تروسنا بالاكيوت يعني التريتمنت قلت ريهايدريشن، شو جيناك للعياده انقلتنا بفلاجيل وانتبايتك. فوين الاورال ريهايدريشن؟ شو ما بقيتنا على الاورال ريهايدريشن. This is our society. We are in the third world community. What we spoke about is just practical for Western countries, which is a sterilized community. There's good public health, inspecting all the restaurants, inspecting the water channels, all they are sterilized community. When there is toxic bacteria entering, the second day the restaurant will be closed and cancelled. The water supply for the houses is clean and 100%. There is no contamination. That is why they don't give antibiotic for those patients with the acute diarrhea, because they are sterilized community. Usually it's viral, but just they give oral rehydration solutions, and unless the patient's having certain toxemia, then we will prescribe antibiotic. But the WHO give clearance for all the Middle East countries or all third world countries to begin with antibiotic, because they know we are not sterilized community. So we are inhabitant with giardiasis. We are inhabitant with enteric fever, typhoid. We are inhabitant with E. coli. So the E. coli, like in our sausage and our sandwich in the restaurant. So that is why the WHO give a clearance for third world community to prescribe antibiotic in case of acute diarrhea not responding for oral rehydration or delaying for more than 3 days. Okay? Now, even if you have significant diarrhea, you can add a drug limiting, a frequency limiting agent like Imodium, choline, bismuth. All these can help you to reduce the diarrhea, especially if you have severe diarrhea. هذا simple algorithm يقسموها إلى mild ومودريت ويشوفوا إنه يعطون نفس هذا حكي اللي حكيته. إذا mild يعطوها بس oral rehydration solution، تقدر تعطي روبرامايد. إذا مودريت وعنده sign of toxicity تقدر تعطي antibiotic وهكذا ويأسس. Just teach it for the algorithm. So we will go directly to the third lectures, which is quite